Hello and welcome everyone to today's webinar for digital implant planning for guided surgery with Dr. Arunachalam. Good afternoon, ladies and gentlemen. This is Dr. Digvijay. I'm the India Country Manager for Ackuretta, and it is my pleasure to welcome you all to this exciting webinar on digital implant planning with our esteemed guest speaker, Dr. Arunachalam. Dr. Arunachalam is a renowned dental implantologist and a prosthodontist with over 2 decades of experience in the field. He is the director at Smiles India, one of the most advanced dental clinics in the country, and has been instrumental in introducing cutting-edge technology and techniques to the dental community in India. Dr. Arunachalam is a prolific speaker and has presented at numerous conferences and workshops, both in India and abroad. He's a fellow of International Congress of Oral Implantologists, the Indian Society of Oral Implantologists, and the Indian Prosthodontic Society, among others. Today, we are privileged to have Dr. Arunachalam with us to share his insights on digital implant planning, a topic that is of great interest to dental professionals worldwide. He will be sharing his expertise on the latest technologies and the techniques in this field, and offering practical tips and advice for clinicians looking to improve their outcomes. Let me give you a brief outline of today's lecture. Dr. Arunachalam will give us an in-depth overview of the benefits of guided implant surgery. He will explain the digital workflow process for implant planning, followed by the discussion of the digital data acquisition and the benefits of using digital data in implant planning. He will touch upon the computer-aided implant planning software and its benefit in achieving precision and accuracy. Last but not the least, Dr. Arunachalam will give us a very important and necessary introduction of 3D printers and materials used, and presentation of real-world clinical cases to illustrate the process. We will finish the session with a live Q&A with Dr. Arunachalam. So we are looking forward to collecting your questions, and I have no doubt that this will be an incredible learning opportunity for all of us. Without further ado, I would like to welcome Dr. Arunachalam to the stage. Thank you for joining us, and we look forward to your presentation, sir. Please.
Thank you, Jay. Thank you, Jasmine, Julie, and everyone else from the Ackuretta team for this wonderful opportunity. It's always a pleasure to meet people from Ackuretta, and it's a great opportunity to share some of my views and thoughts on what 3D printing is as far as daily chairside dentistry is concerned, and how we can enhance the value of our practice, how we can do things far faster, better, and for a much more inexpensive options than what we usually have with traditional or lab-based procedures. So really nice to see people here joining in, and also, I can see Nitish here and Shiv Shankar here, and yeah, it's a nice day. I think I'm looking forward to an interesting day. So let me go ahead and just share my screen. Okay. So today's presentation is essentially about digital implant planning for guided surgery. As the whole idea being that if you were to have a pre-operative assessment, a pre-operative fabrication of a template that enables you to place your implant three-dimensionally in the most accurate or most desirable optimal position, then a good surgical guide is probably one of the best options for you to go. Again, guided surgery could be dynamic in terms of using other navigational aids which are dynamic, or it can also be static. So here today we're going to mainly talk about static guided implant surgery, which means that we prefabricate guides, and these prefabricated guides are either bone on tooth, or they are bone on bone itself, or on soft tissue, and then they act as a template and a guide through which you can go ahead and do your osteotomy, place your implants, and even possibly provide some sort of an intermediate or provisional restoration. So first and foremost, to discuss what the advantages of guided implant surgery are. Then, well, if you look at it, traditionally, implants have been placed more from a osseous plan perspective. That means people begin to place implant based on the bone topography and to ensure osseointegration, rather than being prosthetically driven. So ideally, you want the implants to be prosthetically driven because your patients come to us for teeth, and we want to provide teeth. Implants are just one of the solution options that we have. So in a prosthetically driven plan, if you had a guided procedure, then you will have the preoperative assessment of where the tooth is going to come in, and eventually you can go and center the implant on that prosthetic axis and in the most desirable position so that you have a better outcome. Now, is there, in any day of the week, if you look at the way a guided surgery is being practiced, guided implant placement is definitely through any measure far, far more accurate than a non-guided procedure. Well, there are clinical situations where you have nicely bounded edentulous spaces bounded by teeth on either side. You have a good volume of alveolar bone. You also have a good keratinized tissue. And then, yeah, you can always look through a non-guided procedure. But these are really, really very utopian conditions. Normally, when we open up and at the tissue and look at the bone, we generally decide to go through some sort of a subjective measure as to where we need to position the implant, where we need to, how many implants do we place, how far apart are they going to be, and what is their angle, what is the orientation, so on and so forth. But it's largely dictated by available bone. Whereas when we do a precise planning, and if we can transfer the plan onto a template, then we have a much better outcome. The other thing is that it reduces the time for surgery. It reduces the dilemma, surgical dilemma that we usually find once we open a flap. So the anxiety for the surgery is reduced. Patient is also much more comfortable. You have a much less swelling. You have a much more comfortable outcome for the patient. It saves a lot of time where you are probably doing 1 or 2 cases a day. You might be able to double, triple that figure, do more number of cases per day, restore more number of cases per day. And of course, if you're a novice practitioner, then your learning curve in implant dentistry is also quite reduced. So practically, I think today the standard of care has got to be guided implant procedure rather than freehand non-guided procedures, because we have all the tools necessary. The entire process has become uh, reasonably cost effective. They have it has become far more accurate, far more convenient and accessible. And I think everybody should generally look to doing implants through a guided approach rather than a non-guided approach. Now, to achieve this, what are the things that we require? So we need basically digital data, because most of the planning is done on the computers. We need digital data. And this data is usually in the form of data from the bone, which is CBCT scan data. We also need the intraoral scan data. So we'll have data from the inside the mouth, teeth, and soft tissue. And then with this data, we will need to have some sort of a mechanism to stitch these two together so that we can have a direct representation of our entire tissues, right from inside the mouth to what is there inside the bone, the quality of the bone, the quantity of the bone, and what is its relationship to the adjacent teeth, so on and so forth. Apart from these two data, what we need is a software that helps you plan where you want to position the implants. Now, this software has certain features. This is specifically today, we use both generic CAD software as well as dedicated dental CAD software. So there are some various softwares that are available. So we need these softwares to plan the case. And also we'll need to do, if we are looking to do a completely guided procedure, we need a specific type of a kit called as a guided surgery kit, which has drills which are specific for that implant system of a specific length, of a specific dimension. So you have individual drives, depth specific drills for each clinical situation. So we'll explain all of these in the forthcoming slides, but the general idea is to give you the importance and relevance of what guided implantology is. So today the presentation, my presentation is going to talk about a general flow of what the digital workflow is going to be, how we're going to acquire the data, what are we going to do as far as computer-aided planning is concerned, and how do you design a surgical guide, what are the various printers that we have and what materials you have, and probably I'll run you through one or two clinical cases which have been worked on the computer. So if you looked at the basic workflow scenario, like I said before, we need the CBCT data, which will enable us to assess what the entire bone volume is. And into that bone volume, in the planning software, we are able to position an implant. We are also able to position the approximate pattern or the real pattern of what the abutment is going to be, then create a surgical guide digitally, and then eventually come back and manufacture that guide in the office and go about your regular clinical procedure of placing an implant. So if you see here, we have just walking you through a quick case of what the sequence of operations is. So you saw that we had CBCT data before. We then had intraoral data. This data was in the form of a model that was scanned on a laboratory scanner. And then we had merged the data together. We fabricated or we designed a guide, and then we fabricated the guide, what you saw there. So here, this guide was used to create a flapless procedure where we are actually taking the soft tissue out from the edentulous span and then going ahead with placing your incremental osteotomies until we are able to finally come in and position an implant of an appropriate dimension in the appropriate place with the right depth, the right mesiodistal orientation, the right buccolingual orientation, angulation, so on and so forth. So your positioning of the implant becomes extremely precise and very well planned. 80% of the work here is on planning, 20% of the work here is on execution. And the better part of the entire exercise is that you're also able to design some sort of a provisional restoration, which can also be printed in the office, and then have this provisional restoration cemented onto a temporary or a provisional abutment, and then have a tip in place, which is kept slightly out of occlusion. Have a provisional in place that is kept slightly out of occlusion in this scenario. So not all the cases are amenable for a flapless procedure. Not all the cases are amenable for immediate provisionalization or loading. But nevertheless, if we are able to assess the clinical situation appropriately and come up with a solution for the patient, then we can provide a much better outcome from a planned and guided implant procedure. So having walked you through a brief outline of what the sequence of operations are, let's look at the data that we require. So in terms of data acquisition, we're looking at two sets of data, CBCT data, as well as STL data, either from an impression or from an intraoral scan. And then eventually that gets stitched together onto a software planning program. And in the software planning, implant planning program, we plan the position, number, orientation of the implants, and then we fabricate a surgical guide, and this surgical guide then leads us to having do the surgery on the patient and then have the implant placed. So in terms of digital data acquisition, intraoral scanners are very, very accurate, especially if you're looking at bounded edentulous areas. And they are able to provide us with data as good as, almost as good as what current day siloxane impressions can provide us. They are excellent for dental data rather than completely edentulous spaces, but things are getting better and better, and newer scanners are able to do much more, much faster, and much more predictably than what they used to do before. The next set is also about having a CBCT. So if you see here, we're having a CBCT that is being taken for this patient. Normally for a single arch, we have a certain field of view, and so either we take a single arch or we take the entire full mouth, depending on the clinical scenario. Some of the small newer scanners also help us get some soft tissue around the face, which helps us to position the anterior teeth very nicely. And we have another situation here where we might actually create what is called as a scan appliance, which is a special appliance which has radiographic markers and acts as a template inside the patient's mouth to take a CBCT. And these well-defined markers are again re-looked at on a separate scan of just the template alone, and then this data can be matched. And we'll run you through a case in all of these situations as we come. So as far as the CBCT is concerned, what is it that we read in a CBCT? So in terms of implant planning, there are 7 basic steps that we need to understand in terms of implant planning with the help of a CBCT. So these are, first of all, localization of an important anatomical landmark. This could be a mandibular canal, it could be an tracing of the alveolar nerve. Then we locate and determine the distance to other vital anatomical structures. It can be the floor of the sinus, it can be nasal floor, antenasal spine, whatever. And then we determine the bone density, which gives us a qualitative assessment of what the bone is going to be. We map out the configuration of the bone density in the area of interest, which may be inside the osteotomy, within the implant region, or just bordering the outer border of the implant as well. We can evaluate the alveolar crest thickness, visualize the bone contour. We can precisely position the implant insertion area. We can look at it pre-surgically precisely at the implant insertion area. We can choose the size, type of implant, and how many implants can be placed, whether it's possible at all to place an implant, and also do post-surgical evaluation. So let's run you through some of these steps so it gives you an idea of what we're talking about. So if you look here, one of the first options is to create and identify the mandibular canal and the alveolar bone tracing. If you see here, this is a synthetic panogram that's been taken from the CBCT. It's a reconstructed pan. And on the reconstructed pan, we can identify the canal. We can also look at it through other serial sections, wherein we look at the emergence of the nerve as it exits the metal foramen. And once you've got these across various sections, we are able to create a very photorealistic position of the nerve vis-a-vis the bone, and that helps us to decide where the nerve canal is. Now, the next thing is calculating the distance to the adjacent structure. So if you look at it here, once you've got the canal identified, you're able to calculate various distances. So we have here the distance from the apex of the implant to the inferior alveolar canal or the nerve, and then we can have distance to the lingual cortex. If there are any depressions or changes in the configuration or architecture of the bone, we can have a look at that as well. You can see here there is an orientation of the implant relative to the lower border of the maxillary sinus, and we can actually calculate what the prosthetic angle is, what the implant angle is, what's the difference between the angle, would you like to go for an angle abutment, so on and so forth. So there is a wealth of information that is available through the scans, which will help you decide pre-operatively what the position of the implant is going to be, what its size is going to be, and how you can create a guide and utilize it and you have a computer guided implant surgery. The next thing that we can also do is to measure the density of bone. So if you look here, we can measure the density of bone around the implant site. This is a heat map of the quality of bone around the implant site. So you can see areas of relatively differing densities, areas where you have very good density of bone, as well as areas where you have slightly softer bone. Also, you generate a report of the density of bone that is inside the implant. So you can come back and see here that you have density of bone in the implant, within the socket or within the osteotomy. That will also be some important and relevant feature that will help you. So this report can be generated, shared with the surgeon, or if you're operating, you can look at it and create an idea of what that is going to be. You see here again, you can see a very big depression here in this area, and you can have a rough idea of what the density is going to be. You can see here there's less dense bones here at the crest, and then somewhat increasing densities right at the bottom. So these are values that can help you to understand what is the quality of bone that you are working with. The other thing is to assess the bone thickness and height. So we can know at the immediate subcrestal level what the level of bone is going to be. What's going to be, let's say, 3-4 millimeters below the crest. Do we have to reduce the bone in order to generate a better, have a better diameter implant or a larger diameter implant, so to speak? We can also calculate the distances to the other cortical plates. We can evaluate the contour of the bone. And you see here in this segmented model, we are able to look at which are the areas of the bone that have an optimal density, what are the distances to the nearest large cancellous spaces, so on and so forth. So there is an elaborate understanding of what is the kind of tissue, what is the quality and quantity of tissue that we're dealing with. The next thing that the CBCT also helps us to do, and this is the next sequence that you're going to follow in your planning, is how you choose the implant size. So many of these dedicated CAD softwares, dental CAD softwares, offer you a library of various different implant systems with their associated components. And we can choose these different systems and their various abutments, their sleeves, what have you, and then you can actually orient the axis of the implant relative to the crest of the bone. You can measure distances. You can change translate the position of the bone in all three dimensions, buccolingually, mesiodistally, as well as vertically, and also appreciate what angle it's coming through across serial sections that you will see here. So what is the angle at which it is oriented, what is the angle at which it is emerging, and so on. And then the key thing here is we are always able to begin with the end in mind. You see the tooth here, which has been adjusted to whatever position we want in terms of what its contact with the adjacent tooth is going to be, how it's going to be in occlusion, whether it's following the curve of Sphee and so on. And so this way, we have an end-based planning. That means we know where we are going to end up with, and we plan the implant to that position. The last area where it is useful is in post-surgical evaluation. So this is not generally the standard use, like you do not normally always take post-operative CBCTs, but in those situations when you want to, it's a good idea. We always try and keep the radiation dosage as minimal as possible as far as the patient is concerned, and we do not want to make frivolous prescriptions for CBCTs. Nevertheless, in some situations, it's a good idea to have. This is a case that was done by using a pilot guide. And here you can superimpose the planned and the post-op CBCT views. What you see here is the red views are the planned views. And because it was a pilot guided, simple single guide template, if you see here, the final position of the implants are marginally slightly different, but more or less the exact locations and the depths are more or less the same. So even with an initial level of guide, a fair significant amount of improvement in terms of implant position is possible. So we got a lot of ideas on what this is going to be. The next thing is scanning. Now, this is one of my other pastimes that I really like to do, and I want you to look at this largely because this approach, what you see here, is not particularly the best approach to scan. And I have very, very good associates and assistants in the clinic. Dr. Priyanka is there and Jiva is there. And these two people are so good at scanning that I hardly have learned the art of scanning at all. So what do you basically do in scanning? We are trying to get the intraoral scan data as accurately from the patient's tissues as possible. So you can see here that there is a very fluid movement of the scanner across different parts of the mouth. There is a certain method to this procedure, and if you can follow this flowable action and with experience and doing this again and again, I think they have really perfected the art of getting as accurate detail as possible in the shortest possible time. Also, when you are looking to buy a scanner, of course, there are very different aspects that you're going to look at. One of the things that we are really bothered about in dentistry is how we can get things done as fast as we can, as inexpensively as we can, and with as good quality as we can. So basically, all of these parameters are available. One of the good reviews that you can look at is if you go to Institute of Digital Dentistry, there's a nice review on various different types of scanners, and that will help you also come up with some decisions on what scanners you want to do. So now that we have got these sets of data, the CBCT data and the scan data, the next thing is to align both of these data. What we mean by aligning is that the beauty of planning is that you have different digital sets of information, and these digital sets of information can all be stitched together. And that's the beauty of the entire software. So if you see here, we have a photorealistic representation of what the DICOM data is like. We have the STL data from the intraoral scan, and then now we can identify individual landmarks which are common to both the DICOM as well as the STL, and then let the software itself align this automatically. You can do this manually or you can do this automatically. And you see here that the software has done a reasonably good job of aligning it. You can verify the alignment across various serial cross sections, and where you see that there is a good fidelity between what the data you have in terms of the DICOM as well as the data that you have from the STL. So this means that whatever you are seeing inside the mouth is what you're getting on the CBCT as well. So having done that, so what we have done thus far is to let you know what are the kind of data that you require in terms of CBCT and iOS, or what are the things or 7 steps that you require to do with the CBCT data, and how you can merge both the iOS and the CBCT data together. So once you've got all of these at hand, there are various software that are available for us to be able to plan your implant. So we walked you through a quick single unit case, and I'll walk you through a quick partially edentulous situation, a short span partially edentulous situation. So here the data that you require is an intraoral scan, a CBCT scan. Then you're going to superimpose this that we just saw just now, and then we're going to create a tooth and tissue supported surgical guide. So if you look at this software, what we are doing is we are bringing in the DICOM files, and we'll also bring in the STL files into the software. So we have 2 separate formats of digital data which we are able to bring in. Once we bring in, we try and remove all the excess data. So you see all these floating polygons here, we can take them off. Any extraneous things and things that we don't need, we can clear them off as well, so that the computer doesn't have to use too much processing time. And also we can concentrate on the areas of maximum intensity to create the most appropriate projection that we can have. So we have that. Once the data is all cleaned up, we know what the surface is going to look like. So this is a more cleaned up data. Now we can import the iOS. This is the best intensity projection that you can get, which is most ideal for us to visualize things. So we get the intraoral scan data. Once we get the intraoral scan data, we match both the intraoral scan data as well as the DICOM data that what we saw just in the previous slide. So once we have got that done, we see a super high fidelity response of both the data. We know that all of these are appropriately matching each other perfectly. And so once we have the stitch data that is matching perfectly, we now let the computer decide which is going to be the mandible and what is the panoramic area or curve that we're looking at. So with the panoramic curve, we identify the panoramic curve and inform the software that this is the position of the mandible and this is the curve I'm operating at. And you can see the pan being generated synthetically here at the bottom. And then the process is just the same 7 steps. We look at first identifying the nerve, we look at once we trace the nerve, we convert that into a solid model. So we are able to convert the nerve structure itself, the realistic representation of the nerve structure in an STL model, and we can transmit the model, we can transmit it over the internet to other systems or to other software. So you see here that the nerve has been identified and has been generated. So once we have done that, we can look up at the teeth. So we choose the tooth that we're going to replace. So we select the tooth, we position it, we orient it appropriately, we make sure that it's in the most ideal position. Whatever be the number of edentulous elements that you have them in the proper orientation with the proper curve in occlusion, and then with all your positioning principles of prosthetics, and then come in with your implant selection. So in your implant selection, you have various implant options that are available, and these implant options you can choose these options, and then you can pick and play around with whatever sizes you have. So here you see that we've tried a 10 millimeter implant, and then we'll try and see you can orient it appropriately, keep the appropriate distances from the adjacent tooth. You can then try and see if we can change it into a 12 millimeter implant. And so when we do that, we begin to see that, okay, so maybe we can move it with a 12 millimeter implant. This is a 4x10, so we can position it wherever you want. And then we can choose these sizes. We can plug and play different dimensions of implants, and that will help us to select an appropriate diameter. So we can keep that inventory with us when we are working on the case. So this is the 1 and the 2 implants that we got in position. We can then measure all the distances that we need. And eventually, so when we transfer this onto the surfaces, we are able to create and trim the intraoral scan data, additional data, superimpose this on the data, and create the surgical guide itself based on that. So here is what the procedure for creating the surgical guide. We remove all other extraneous data, and then we have just brought in or ticked in just the implants as well as the guide sleeves or guide cylinders outside. Then in order to create the guide, we just block the undercuts so that we can have a guide that can freely slide in and out of tissues without impinging them and causing discomfort for the patient while the operation is on. So the guide itself fits smoothly and comes out easily, but at the same time is very stable and is at the best depth that you want it to be, supported by tissue and teeth all around. So once it's done, it's just a simple matter for the AI. If you can identify what is the extent of the area where you want the guide to be, a guide is automatically generated like this. And once you have the guide generated, you can trim, smoothen, and finish the edges as much as you want. And after that is done, you can cut the holes into where the osteotomy guide is going to be. You can also cut open some inspection windows, so you get to see whether the implant is seated appropriately or at the best depth. And then that's it, more or less, your guide is more or less ready for you to be able to transport. And this is the guide you have. You can also set the timing or the orientation of the hex of the implant to whichever direction you want, and you have the final guide that's been finished and it's been labeled with the patient's name, and you have everything in place. So this is a partially edentulous situation where you have a workflow for a partially edentulous situation. These are some of the guides that we normally use. You see here, you can also create channels for irrigation if you want. You can also create channels for giving posterior palatine blocks if you wish, so on and so forth. So there are lots of things you can play around with. The next more complicated scenario would be for somebody who has a terminal dentition where you're planning to extract all the teeth and create a bone level guide. So today you have a lot of software where you are able to produce, do what is called as a segmentation of the tissues that you need. Segmentation is the ability for you, or the process by which you look at things of isodensity or similar density, identify them as the same object, and then separate them into various STLs. So you could have bone segmentation, which means the entire mandible or maxilla, what have you, can be segmented out separately. You can have segmentation of teeth. So if you see here, we are segmenting teeth here, and we can separate and extract each of these teeth separately. So we can get the post-extraction view of the patient digitally, because we've digitally extracted all of these teeth. And There are many different softwares that are available for this. We are very fond of this particular software called Relu, which helps us to do this. Even today, you have other softwares that do this as well. So once you've done that, when you look at a full mouth case for full mouth terminal dentition, where you're planning on extraction and placing of implants simultaneously, the principles still remain the same. The 7 steps still remain the same. We have intraoral scan data, we have digital data, and we're getting all of these data inside. Now, when the patient desires to have an appearance slightly different from what it to wear, we can also do what's called as a digital wax up. So you see here that we identify the midline, we identify the occlusal plane, and looking at how much distance we have, we can create a digital wax up, determine the implant position. So you see here the midline is being determined. The superior position or the platform position of the implant, upper implant is at the top, the platform position of the lower implants at the bottom. So we wax up, we create a digital wax up, we align the digital wax up to the CBCTs, and now since all of these are paired together, you have all the data, match data, which are simultaneous. So this is the newer position of the teeth that we want to generate. So with this, we create what is called as a guide. But before we create a guide, we create something like a scaffold. Now, the purpose of the scaffold is to create some kind of a template on which, if you see this template on which future stackable components can go in. So you have a scaffold like this, which is fixed onto the tissue with the help of guide pins or guide screws. And it has got some retentive areas on which you can stack the next set of guides. So you can stack the next osteotomy guide, you can stack the next provisional, you can stack the next timing guide, so on and so forth. So this is the sequence of operations. You have the guide pins here. We have this particular case, we had a tooth indexed guide with a bone reduction guide. So if you see here, this is a guide. This is a scaffold guide, which has been positioned to the exact position what you saw in the facial plane before. I showed you the previous section where we had the midline, the occlusal plane, and the waxed up, and the superior and inferior positions of the implant platforms. So this is exactly coincides with where the implant is going to finally end up. And this can also double up as the bone reduction guide. So you will see here that the teeth are being kept here before extraction to orient the scaffold. And once the scaffold is oriented in the right position and fixed with fixation pins, the teeth can be extracted. And this entire structure itself, if you level the bone up to this, you have a automatic bone reduction guide. Now that's a virtual reduction of the bone, on top of which the implant osteotomy guide can sit in. And once the implant osteotomy guide sits in, we can go ahead and perform your osteotomy very precisely in the best possible dimension of bone that you want. You can also make a provisional denture, which can be picked up at the time of surgery, and some sort of a provisionalization can be provided for the patient. So the same situation for the lower arch, the same thing holds good for the lower arch. You have the same scaffold guide on the lower arch, and you have the which also doubles up at the bone as the bone reduction guide. The planned implant positions are then coded into the implant osteotomy guide, and then eventually you can go ahead, place the implants, and be ready with your provisional restorations. So that's a quick overview of what an immediate extraction implant stackable guide option is going to look like. The last option is probably a completely edentulous situation, where we say that we can also create what is called as a soft tissue supported guide. Again, the principles are the same. We import the right kind of CBCT and DICOM data. We also follow the same process of identifying the nerve, selecting and choosing the implant, getting the IOS data. But in this case, one of the variations that we do is we generate what's called as a scan appliance. So here we fabricate, it's a hybrid analog digital option that we use. We fabricate a denture which has got markers on it. And these radiographic markers, the patient wears these radiographic markers and takes the CBCT. And there is also a separate second CBCT, which is taken of just the template alone, or of just the radiographic marker containing denture alone. So which means that we have a dual scan protocol. So in this dual scan protocol, we are able to, once we have the data from this dual scan, we have data of these markers in the denture, and we have data with the denture in the patient's mouth. So what we can then do is we can segment all of these separately. We can segment the markers separately. We can segment the denture separately. We can also identify the markers in the patient's CBCT here and here and here and here, where when the patient was wearing the denture. So you can change the threshold and you can actually look at this. So once we have it, we have identifiable landmarks from the CBCT, which can be tracked to the landmarks on the denture itself. And this way, we again do the same process of matching both of these data. So once we have matched both of these data, we can align the denture to the DICOM data. And you see that the denture is directly in the DICOM data. And then now we know the positions of the teeth. We know the positions of where the bone is relative to the different, implant positions. And then it's again the same sequence of implant planning. We choose the number, site, orientation, dimension of the implant. We can also choose the prosthetic angle. If you're choosing multi-unit abutments of various, you have options with which you can change the orientation and make sure that the exit path of all of these abutments is all parallel to one another. So once we have that, we also have guide pin manufacturing area. So we make use of guide pins to hold the scaffold guide in place, which you saw earlier. So we have all of these parallel to one another. We have the scaffold, and the denture itself doubles up as your template or as your guide, and you can have that position and make your osteotomy right from that. So the denture is itself converted into a surgical guide. You create the holes. These are the fixation pin holes. These are the osteotomy holes. And this is how the fidelity of the denture is with respect to the CBCT. So as long as the analogous denture is seating inside the patient's mouth perfectly without any gap and in occlusion, you can get a perfect positioning of the denture inside CBCT. Right. So having done that, so what we have done thus far is walked you through a series of different cases where you have a single tooth situation, you have a partially edentulous span, you have a condition where there is imminent extraction and there is going to be an implant placed right after the extraction with some sort of provisionalization after that. And we walked you also through a completely edentulous situation where you use a scan appliance or a denture as a marker and then go ahead with your final thing, with your final implant placement. Following this is, once you have all from the digital world, we now come into the real world where we try to convert whatever we have fabricated digitally into the reality of a surgical guide. And now, surgical guide manufacturing is a pretty interesting and a very enthusiasm involving objective or a field. There are many different types of printers, and I think today, if you look at what you really need, you need to look at some sort of an accurate printer, which has a good level of accuracy and resolution, and is able to print with a good level of acceptable surface roughness. And one of the best options that we have come across is the Ackuretta Sol, which is a very accurate printer, which has a very, very good resolution. Also, Ackuretta produces some of the finest surgical guide resins. One of the most difficult things to print is a transparent guide resin. And I think what the job that the Ackuretta CURO resin, surgical guide resin, and the Sol do is really remarkable. And we'll run you through one example. So now, before you are able to actually convert your virtual design of the guide into reality or into a practical resin guide, we need to print this out. And printing requires that you are three-dimensionally layering the print itself. So if you looked at it, you will have multiple slices of layers, and each of these slices of layers will be cured independently, and then cumulatively they will all add up to create a nice three-dimensional structure. So in order to do that, there are several factors that need to be taken into account. And one of the key elements, and I'll emphasize this quite significantly, one of the key factors in converting this digital information into the real world information is your ability to slice the data perfectly for this additive manufacture, and also your ability to orient the manner in which the printing is going to take place, your type of supports that you require, what is going to be the, the parameters that are relevant to that particular resin and so on. So all I want to say is there are a large number of factors that you have to consider when you're looking at the kind of printer or the kind of slicer software that you're going to use. Accuretta's latest slicer software is an AI-driven software, so which means that many of these parameters in terms of how many supports are required, where these supports are required, how thick they should be, what is going to be the transition between the thick area and the thin area. All of these factors are all largely determined by AI. They are AI driven, and therefore, what could normally take you 10 minutes to figure out on a manual slicer, you can do this in less than a minute. It's really, really fast. There are many different options for crowns, bridges, plinths, as well as surgical guides. And if you use this option, you're able to generate your surgical guide fairly easily. So if you see here, all we have to do is just position the guide in the middle of the projected plate, build plate, and then the software is going to do all of these activities themselves. It's going to orient itself, generate its own support. So it generates the supports, the elbows, the base layer, transition layers, everything. And then you can add or delete what you like. It is careful enough not to place any supports in critical areas, and therefore you really don't have too much work to do. Once you have done this, you can then have all the slices that are available, so you can know how many slices are going to be there, and you know the spacing between these slices. You can also run through a slider here which lets you know the sequence in which this is going to be. Most of our printing is done bottom up, so we can see the sequence at which this is run and make sure that each particular slice or layer is well supported with adequate number and size of the supports as well. So then it's just a question of being able to go ahead and start the print. There is a printer queue into which you can send this, and then you can set the print out. And normally in a medium platform, you should be able to print a surgical guide in less than half an hour, close to. So in terms of the resins that Accuretta has, there is a wide range of resins that Accuretta sells, and and not only that, Accuretta Sol as a printer is validated for several different resins from across the world. Now, one of the most important things in most of the printers is your ability to calibrate the printer right at the beginning. So a key thing when you're looking at a printer is also adequate tech support. We've been fortunate enough to have absolutely fantastic tech support from Accuretta. Not that you need it that often, but then we've had the opportunity to interact with them. And whenever we have a newer resin or we have a newer protocol for that matter, then we are able to team up with the technical team of Accuretta and come up with their support for our thing, and they are able to guide us into calibrating our machines, which again needs to be done every time, maybe once every 6 months or so. All of these are regular real life products. So if you're looking at a light based polymerization, photopolymerization, and I don't know how much of you will remember that almost all of these have a certain life. So over a period of time, the intensity of the light can diminish. So many things can happen. So it's important for you to have a printer with whom you get very good technical support, so that you can calibrate it often and make sure that the accuracy and precision with which you're able to print your guides is maintained really well. Many of the guide materials that you have very good shelf life, and the dispersion of the various elements there is also pretty good. So you get a very satisfactory print, and you can also ensure it's a biocompatible product, so for use inside the patient's mouth. So all of these things are very, very significant as far as printing is concerned. The surgical guide by themselves is an autoclavable transparent guide. Autoclavability is a very, very important property. And so especially because you're going to use this right at surgery, and also it has very good good high tensile strength. So there is a possibility for you, if you're not careful during the implant placement, that you stretch and tug at the guide, and if the guide doesn't have enough strength, then it can break. Now, one of the problems of guided surgery, I won't say a problem, is that if you suddenly decide to change your plan, and if you choose an alternative pathway, For example, if you're going through a planned flapless procedure and you want to suddenly change to a flap procedure, if your design of the guide supports that flap procedure, then it's a different story. You can still work with it. Otherwise, you will have to improvise and come up with some idea to be able to position your implants appropriately and adequately. So all I'm trying to emphasize is that a guide is not going to replace a certain skill or clinical acumen that you develop, but at the same time, it's going to make your job a lot more convenient, easy, and faster in regular terms. So the thing with the Ackuretta resin is that it's biocompatible, so you can autoclave it, and it's got very good flexural strength, flex toughness, good hardness, and you're able to, and it's one of the few good transparent resins that can be printed. It's very, very difficult to print a transparent resin from purely physics point of view. But if you look at the way in which this splint guide prints and the accuracy of the prints, I think it's pretty impressive. So in a medium build platform with the Ackuretta sole, in about half an hour, you can have a surgical guide printed. In a large build platform, it usually takes 3/4 of an hour. And the cost per print is about $1 per print, which is pretty impressive because the amount of saving that you have in terms of your less rework on all of your cases itself, I think that's a big plus. So this is the Ackuretta itself is known for its speed as well as for its accuracy and precision. You get pretty fast 3D printing. It's an MSLA type printer, so it's a mass SLA type printer. So you have a very precise and very accurate pixel size and the Z resolution, which helps us to have a very good print as well. Okay, so just running you through what the print looks like. So this is a regular platform or the large platform that you see. So you see the platform that's entering into the resin, and then there is like I said, it prints bottom up. So you have the prosthesis or the guide sitting onto the build plate. And once you have that taken out, the post-processing is, once the printing is done, we run it through a post-processing. The post-processing is usually a series of dips and washes in a IPA solution, isopropyl alcohol solution, and then you photopolymerize this in thing. So Ackuretta also makes a very good wash called CLEANI, and also makes an excellent curing system called CURIE. They have recently renovated their, or rather providing a nitrogen-based curing system as well, which is very, very impressive. We saw that at the IBS in Coron, where the atmospheric nitrogen is taken and concentrated, and in that nitrogen medium, or an oxygen-inhibited medium, you have a much more reliable curing that happens. So I think that's a big step forward. Okay, so yeah, so that I think with that we have a almost a wrap on what we intended to talk about this morning. So what I ran you through is a basic workflow of what digital dentistry is, from a single tooth situation to a completely edentulous situation, and walked you past a partially edentulous situation as well as a clinical scenario where you're going to extract teeth and place implants then and there. Like I said before, the guided surgery is probably the standard of care today. As things become less expensive, more accurate, more predictable, everyday dentistry on the chair side can be achieved. I think it is very, very important that not only experienced practitioners, but also novice practitioners get into guided surgery as the normal mode of operation, because the level of exactness that it affords, the safety that it has, the predictability of your implant position, orientation, angulation, your ability to plan the prosthesis up front, you're reducing the morbidity of the patient, increasing the patient comfort, and an increasing number of flapless procedures that you can do. Not that everything can be flapless, but a large number, a lot more flapless procedures can be done predictably, which means not only are you preserving the bone morphology, you're also preserving the soft tissue architecture, which is an excellent thing. And then the ability for you to immediately temporize, and all of these, I think, are possible scope for you to move to 3D printing. So if you have been sitting on the fence or on the edge as to what should I be doing. Should I be getting into 3D printing in the office and working on creating my own surgical guides? I think this is just about the best time for you to do this. And I do hope this presentation will encourage you, or those of you who are just on the fence on whether to get into this or not, will be motivated to get into this. We do prints every day. It's become a routine part of our daily dentistry experience in the practice. And I'm very, very fortunate to have a good team who can help me around and work with this. So I'd like to acknowledge the help from Team Ackuretta, especially Ayush, Julia, and Jasmine, and of course Jay, who is the India manager and introduced me right at the beginning. 𝗙𝗏𝗃, he's also from Chennai. So I look forward to meeting him too. And of course, my sincere thanks to Dr. Priyanka, who takes care of the entire digital element of our clinic, and to Jiva, who supports her, my other assistant, and of course, all the nurses and the doctors and team from Science India. So thank you very much for this wonderful opportunity. I really enjoyed making this presentation, and I hope you could take something back.
Thank you so much, sir. I was totally mesmerized with the the kind of a knowledge which you have imparted within a small span of time. And I feel it's a very we have actually, you have taken us through a very knowledgeable journey within a very small span of time, and we have seen so many data, so many information being provided, and discussed so many topics within such a small journey, and we feel so delighted to have you today, and you have shared so much of your experience. Further, I can see in the questions section, we have a question from Dr. Mohan Satish Shanmugam. He's asking about how about its precision in atrophied ridges when going for a pterygoid or zygomatic zygoma, sir.
Okay. One of the things that we need to get is the kind of data that we're talking about. Now, if it were for a pterygoid or for a zygoma, my preference is usually to go for a thicker section. Now, in the CBCT itself, if you take a CT scan and you have a thicker section, the ability to identify landmarks and pathologies is much better on a CT. And the thinner section can let you look at very fine lines and very fine detail, but a thicker section is a far more reliable indicator of anatomical landmarks. So normally the go-to option in terms of CT data is general CT, not CBCT, but the standard medical CT. So we take that CT information. So once we have that CT information, then it's a question of being able to segment the bone appropriately. So we do make guides for the zygoma. We also make some guides for the pterygoid. And if you know the landmarks and if you're able to segment the bone appropriately, it's fairly accurate. I don't think you should have a significant problem.
That's wonderful, sir. Apart from that, I have a small question from you as well. How do you find the accuracy of the surgical guides, and how the current the 3D printers stand? Like, you are using a 3D printer currently, a Sol,
Yeah.
and how do you find the accuracy?
Oh, it's really, really good. I mean, there are a lot of factors that go into the accuracy of any guide that you manufacture. A part of that is in the design of the guide and so on, but a significant part of that is also based on the printer, the specs of the printer, the ability of being able to, of the slicing software to appropriately orient and print the various transition layers, like negative layers like holes should be printed accurately, thicker layers should be printed accurately as well, and then it has to have a good resolution, it has to have a reasonably good surface. So all of these factors add up. There are, and of course there are factors with the printer as well. So the rate at which the printing is happens, the speed at which the print bed goes up and down. There are a large number of factors. So the key here is to choose a dedicated dental printer. And I think from that perspective, Ackuretta actually hits just the right spots, because It helps you to run a very precise print and an accurate print and a fast print. So I think, and with the newer, 3 different platforms that you have for various applications, other than even for guides, I think the speed with which you can get things done is much better. So I'm really impressed. And like I said before, there is always a queue in the printing. There's always a queue in the scanning in the clinic. So you can understand how busy
Awesome, sir.
that element is. Yeah.
Awesome. Meanwhile, we have a question from Dr. Mohammed Zaved. He's asking how we add metal sleeves to the surgical guide.
All right, that's a good question. Normally, in most of the softwares, there is a provision to add the sleeve. So there are some companies provide sleeves of different dimensions. So you can have, for example, if you looked at Bredent as an example, they provide a 4 mm sleeve and a 6 mm sleeve. So when you have, you can incorporate these sleeves in the design. So once you have incorporated the sleeves in the design, eventually when you print it out in resin without the sleeves. And then what you do is you place this, after you have washed it in the IP and remove the excess resin, you can place the sleeves in and go for your curing. So in the post-processing span or of your workflow, you are adding the sleeves which you can buy from Britain, for example. You can buy the sleeves from Britain, and then you can position the sleeves into the appropriate slots, and then you do your post curing. So that way you have the metal sleeves which are incorporated inside the guide. And yeah, well, there are sleeve-less systems, and there are systems with sleeve. For instance, if you looked at Hyoscine or Austin, for example, they have a sleeveless system. So in the shank of their own guide kit, it's completely smooth, and they claim there's really not much of a necessity for us to use a sleeve. But some other systems are so very strict about having a sleeve, and then they have sleeve. The other thing that sleeve does, it helps you to orient the hex of the implant really, really well. So sometimes you may have a hex that's built into the sleeve, so your timing of your implant is really accurate. So there are pluses on both the sides. The minuses are that the sleeves are also another add-on cost, but without sleeves, it's a little faster and just more. If you have the correct systems, it does the same job.
Wonderful, sir. Wonderful. I think today was an eye opener, and it will encourage the beginners to enter the digital dentistry, and with the topic which we have covered today, with your immense presence and lot of knowledge. Actually, we got to learn so many things today. There were I have noted down so many topics which it was quite new to me, like post-surgical evaluations, tooth index guide and bone reduction guides, implant osteology guide, provisional denture fabrication. So those were the topics which are quite an eye-opener. You have just took us through a full implantology, digital dentistry implantology within a quick span of time. That was amazing, sir.
Thank you very much.
Thank you so much, sir. Thank you. Anybody will have any other questions? We have Dr. Arunachalam ready right now. Or in case if the webinar gets over, you all can drop us your queries or any other information which you need at digvijay.singh@accuretta.com. And we will be happy to provide support or any other information. Thank you so much, sir. Thank you so much, Dr. Arunachalam. Thank you so much, Jasmine. Thank you so much to all the participants who have today actually spared some of their time from their busy schedule to join us. Thank you so much.
Thanks a lot. Really my pleasure.
Thank you.
Bye.
And later we will having an upcoming seminar on fail-safe printing by Dr. Nitish Surathu on April 13th. And the timing for India will be 1 p.m. for Singapore, 3:30 p.m. and 7:30 p.m. for New Zealand. And we will be giving a chance for a 1-year Alpha AI premium slicing software.